all of you, and welcome to the academic program conducted by the GMO Academic Subcommittee. Today's topic is management of malnutrition in children. We have invited Dr. Mallawarachchi, who is the consultant clinical nutrition physician at Lady Ridgeway Hospital for Children in Colombo. Dr. Malnutrition has obtained her MBBS from Faculty of Medicine, University of California in 2006. She has completed the MSc in Human Nutrition in 2016 and obtained her MD in Clinical Nutrition in 2020. She has obtained a special training in pre-surgical and post-surgical long-term nutritional follow-up of bariatric patients at Salford Royal Hospital, UK, which is one of the largest bariatric centers in the world. She also is a member of the Council of Sri Lanka College of Nutrition Physicians. So let me warmly welcome Dr. Mallawarachchi for today's academic call. And if you have any questions, please send them over through the chat box. We can attend to those questions at the end of the lecture.
Thank you so much for the kind introduction. So we'll start the presentation now. The topic is management of malnutrition in children.
Why do we talk about malnutrition? So malnutrition can lead to increased infections, increased complications, and reduced convalescence. It increases morbidity and mortality, and therefore increase hospital length of stay. As a result of that, it results in healthcare cost, quality of life, and reduce the quality of life. If we talk about malnutrition in children, over the last few years in our country, there is recent rising numbers of malnutrition after the economical crisis, and obesity and overweight also rising. Even though we think it might reduce with this economical crisis, we have observed there is rising numbers of obesity and overweight among the children. So the cause could be due to lack of healthy food. And now we consider obesity as a disease as well. WHO has published a new guideline on malnutrition among children under 5 years. For that management, for that guideline, they have discussed about management of wasting and nutritional edema. It was published very recently in June 2023. What is the definition of malnutrition? Deficiencies, excesses or imbalances in a person's intake of energy or nutrients. So under that, underweight, stunting, wasting is considered as undernutrition, and micronutrient deficiencies, micronutrient excesses considered as micronutrient related malnutrition. Overweight, obesity and diet related non-communicable diseases are also another aspect of malnutrition. So this is what we are holding as triple burden of malnutrition. So according to the newest guideline, they talk about 3 new areas of focus. One is infants less than 6 months of age at risk of poor growth and development. Under that, infants with wasting or nutritional edema are a subset, and moderate wasting in infants and children 6 to 59 months of age, and also prevention of wasting is also discussed. What are the criteria defined to identify at risk of poor growth and development under 6 months? So one group is infants with poor growth based on sequential measures. If there is no weight gain or weight loss from one measurement to the next, or downward crossing of weight for age centile lines, or insufficient weight gain, we consider it as poor growth based on sequential measures. And infants with poor anthropometry based on single measures. If the weight for age score is less than -2 st, if the weight for length score is less than -2 st, or with the presence of nutrition edema, or mid-upper arm circumference less than 110 millimeter for infants between 6 weeks to 6 months of age. Those are taken as infants with poor anthropometry based on single measurement. Third group is infants with no risk factors for poor growth and development. Those are children with neurological development concerns, infant feeding concerns, maternal risk, and history of hospitalization. Who are the infants at risk due to poor birth outcomes? Preterm birth, low birth weight, small for gestational age. Those infants are anyhow having risk due to poor birth outcome. So as you can see in this picture, what I described was the children, the infants who are less than 6 months having poor growth and development. So we have to have a good concern, a good identification and management of these children. What is the management of them? Our goal is to early detection of any acute medical or psychological problem and preventing infants from becoming severely underweight or severely wasted. So in short term, it is to prevent severe malnutrition or getting complications. What we should do now? Comprehensive medical assessment of these babies, medical intervention when necessary, growth monitoring and promotion, and also breastfeeding assessment and support for non-breastfed infants, physical and mental health assessment of the mother and caregiver, health education, counseling on infant and young child feeding where necessary. So it is very important management of these children with high risk of growth and development. So if we talk about infants less than 6 months of age at risk of poor growth and development, that should be admitted for inpatient care. If the baby is having one or more danger signs, acute medical problems or conditions, nutritional edema, recent weight loss, in the absence of any of the above criteria, we should consider admission after in-depth assessment based on clinical judgment. So what are the danger signs that we should consider? If the baby is not able to drink or breastfeed, vomits everything, had convulsions recently, lethargic or unconscious, convulsing now. So those are the danger signs that we should consider immediate inpatient care. What are the acute medical problems? Signs of possible serious bacterial infection in infants less than 2 months of age, shock, oxygen saturation less than 90%, pneumonia with chest involving and fast breathing and possible measures, and oxygen saturation of less than 94%, dehydration, severe persistent diarrhea. Likewise, there are medical problems that we should consider inpatient care. So if we go to the management of infants who are less than 6 months of age with wasting and nutritional edema who are admitted to inpatient care. After admission, we should try to breastfeed where possible, and if the breastfeeding is not adequate, we should go for supplementary feed, that is feeding from another source rather than pure breastfeed. So we can try supplementary suckling. As you can see in this picture, it is called supplementary suckling that we can help the baby in developing breastfeeding while taking formula feeds as well. For infants with edema, expressed breast milk, commercial infant formula or F75 or diluted F100 should be given. But in the absence of F75 or diluted F100, what we are doing in the hospital is give expressed breast milk or commercial infant formula. For infants with edema, we can give commercial infant formula or F75. If unable to breastfeed, replacement feeds such as commercial infant formula should be given. What we know about malnutrition. So we were talking all these years about severe acute malnutrition and moderate acute malnutrition between 6 to 59 months of age. So you know severe acute malnutrition is less than minus 3 ST in the weight chart, weight for height chart or weight for length chart. If it is between minus 2 ST to minus 3 ST, it is called moderate acute malnutrition. So what is new? Now, according to these new guidelines and now the current practices, we don't call them as acute malnutrition. The new terminology is wasting and nutritional edema. Of course, severe acute malnutrition is also in practice. The other newest term is severe wasting and nutritional edema. If there is nutritional edema, or weight for height score or weight for length score is less than minus 3 ST or mid upper arm circumference less than 115 millimeter, we call it as severe wasting or nutritional edema. And what is moderate acute malnutrition or moderate wasting according to the new terminology? Weight for height score or weight for length score less than minus 2 ST to minus 2 ST to minus 3 ST or mid upper arm circumference between 115 to 125, and in the absence of nutritional edema we can call it as moderate wasting. So when there is nutritional edema, it is always severe wasting. In the absence of nutritional edema, it should be moderate wasting when the infant meeting the criteria that I discussed. What are the criteria that we should consider in a child between 6 to 59 months with severe wasting to be admitted for the inpatient care? One or more danger signs, acute medical problems, severe nutritional edema, poor appetite. That is poor appetite. We do the appetite test at the clinic. We can offer ready-to-use therapeutic food, that is BP100. So if the child is not taking enough BP100, that is ready-to-use therapeutic food, we have to admit child for the inpatient care. So in the absence of any of the above criteria, we should consider admission after in-depth assessment based on clinical judgment. So danger signs are, as I discussed earlier, those are same for the children less than 6 months of severe wasting. So if the danger signs are there, we should admit, or if the acute medical problems are there, we should admit. We'll look into the management of severe wasting in patient care. In the stabilization phase, when the life-threatening complications are treated, we can use F75 for the nutrition stabilization. It's a low-protein milk-based formula. So as I told you earlier, it is not available in our setting. So what we can use is a commercial formula that contains 75 kilocalories in 100 ml. In rehabilitation phase, it is the phase where catch-up growth occurs, and we should transit that F75 to F100 formula. It is a F100 is a milk formula with higher proteins and higher energy. So once the sepsis and metabolic abnormalities are managed effectively, we can transit F75 to F100. Later, when the baby is stabilizing, when the child is tolerating F100, we can turn this F100 into ready-to-use therapeutic food. And you should be careful. We should look into renal solute load, because this formula, this is ready-to-use therapeutic food high in electrolytes. It can worsen the renal function, if there is renal impairment, so we should consider about renal solute load as well. So we'll discuss a case scenario. This is a baby with reticular septal defect, total cleft palate and peri-Robin sequence with development delay. He was admitted to the hospital at the age of 4 months. He has had a recurrent hospital admissions and ICU admission after 4 months. So this is the baby who was transferred from medical ICU to the general pediatric ward. As you can see here in the upper picture, this is about 2-3 days after the admission. He was severely malnourished on admission. He was on the NG tube and nasopharyngeal tube due to complication. He has had upper airway obstruction, difficulty in getting feeds, so NG tube and nasopharyngeal tube was in situ. And he was started on commercial formula feeds, given with concentrated feeds later, and we had to try prokinetics as well because there was intolerance. Later we shifted into infusion feeds with intolerance. It was like very difficult to manage enteral feeds. But anyhow, with all the support, we were able to establish the feeds later. And rather than waiting for 6 months, we had to start ready-to-use therapeutic food earlier in this baby. So at that time, we were careful to look after renal solute load, electrolytes, everything. So as you can see here in this weight chart, there was an initial weight drop and baby was having a poor growth until 4 months. After nutritional rehabilitation, he was gaining the weight, and you can see he is catching up the growth up to his birth trajectory. So at the age of 1 year, baby is he was really fine. There was no development delay actually, even though he was having noticeable development delay in the infancy. His gross motor function, fine motor, everything was fine at the age of 1 year, and his PST was closed spontaneously, had undergone the repair of total cleft palate, and actually he was more or less equal to a normal baby. So what I'm trying to tell you from this case scenario is, if you manage the nutrition properly, you can overcome medical complications, and we can have a very good outcome of these children. So we'll see what is the outpatient management of infants and children 6 to 59 months of age with severe wasting. What we use in the outpatient setting is ready-to-use therapeutic food. It should be given a quantity to supply energy of 150 to 185 kilocalories per kg per day until the child is no longer severely wasted and does not have nutritional edema. So our target weight gain from that is 5 to 10 grams per kg per day. When we are refeeding a child, we should be very careful about refeeding syndrome. It's a potentially fatal shift in fluids and electrolytes that occur in a malnourished patient receiving refeeding that may cause serious clinical complications. If we look at the pathophysiology of refeeding syndrome, when the child is not getting any feeds, in the malnutrition state, there is high rate of catabolism, low insulin levels and high glucagon levels. This causes glycogenolysis and increased protein catabolism, high gluconeogenesis, and reduced vitamin and mineral levels in the body. And when you refeed, carbohydrate will be taken as the main energy source, thereby insulin secretion will be increased. As a result of that, there is high protein synthesis, sodium retention, glucose uptake will be higher, and thiamine use will be higher. And because of the activation of ATP pump, there is intracellular shift of potassium, magnesium, and phosphate. So as a result of all these things, there will be hypophosphatemia, hypomagnesemia, hypokalemia, thiamine deficiency, salt and water retention, hypoglycemia, and hypothermia. So at this stage, we can call it refeeding syndrome. What are the complications of electrolyte imbalance when refeeding a malnourished child? So, as I told earlier, there is hypophosphatemia. Hypophosphatemia can cause cardiac arrhythmias and sudden death, congestive heart failure, respiratory failure, renal failure from osmotic diuresis, hemolysis, and altered mental status. So hypophosphatemia is the hallmark feature of refeeding syndrome. I must say it is like not a good practice in our hospital setting to monitor serum phosphate levels. So you can see there are a lot of complications that can occur from hypophosphatemia. So it is a very good practice if you could do the phosphate levels while you are refeeding a child to prevent those complications. So when you do the phosphate levels, it should be taken after 4 hours fasting. And potassium can cause cardiac arrhythmias, respiratory failure, paresthesia, paralysis, seizures, ileus, rhabdomyolysis. And hypomagnesemia also can cause similar type of problems, those which are fatal. And thiamine deficiency can lead to Korsakoff syndrome, Wernicke's encephalopathy. So how do we supply these electrolytes while refeeding the child? If the sodium is low, we have to give 1 to 2 millimoles per kg per day, and potassium for the maintenance 1 to 2 millimoles per kg per day, magnesium 0.1 to 0.2 millimoles per kg per day, phosphate 0.1 to 0.2 millimoles per kg per day if you are giving parenteral. So you know it is not available, the phosphate supplements, IV preparation is not available in our country. What we give is enteral or oral phosphate supplement. We have phosphate buffer which is called Joule solution, and also sodium acid phosphate tablets are also available. From that we can give phosphate 1 millimole per kg per day to prevent hypophosphatemia, and calcium 0.05 millimoles per kg per day. This is about management of infants and children aged 6 to 59 months of age with moderate wasting. This is about moderate wasting which could be managed in the outpatient setting. So we should advise on nutrient-dense diet, supplementation with specially formulated foods. So for that we give Triposha. What is available is the Triposha as the supplementary food. So the total daily energy requirement should be about 100 to 130 kilocalories per kg per day for come out of moderate wasting. Rather than waiting for all these problems like moderate wasting, severe wasting, it is very good if we can identify these problems early. So identification of growth problems can be done by monitoring the weight for age chart. If there is weight for age less than -3 SD, we call it severe underweight. If it is between -2 SD to -3 SD, we call it moderate underweight. Even the baby's weight is within this green zone. If there is weight loss for about 1 month, we should identify that. And when there is growth faltering, like flattening for 1 month, we should have proper attention. And when there is growth faltering in green zone for 2 months, we have to identify them and advise accordingly. And crossing the growth trajectory also very important. We were always now talking about this growth faltering and malnutrition. Likewise, it is also very important to identify crossing the growth trajectory upwards. So here you can see this child is having a shooting of weight from 4 months onwards. So he is crossing his birth trajectory. It is very important to identify that. So he is going towards the obesity. If he goes beyond this green zone, it's very difficult to control from the behavior modification. So early identification is very important rather than waiting until crossing like 2 STs. It is very important that child is going to have obesity. So early referral to any nutrition care is very important. So now we'll talk about stunting. Stunting is if the height for age is less than -2 st in under 5 and 5 to 19 years. It is not well identified in the primary care setting because there is not much knowledge about stunting, but there might be underlying problem. So we should investigate stunting as well. After 2 years, of course, we can plot the child's height in the mid-parental height and see the height is within the mid-parental range. So from that we can see if the height is within the genetic potential. If not, actually we have to investigate. If we don't think this is due to genetic problem, we should always go for the investigations. Overweight and obesity, as I told you earlier, it is a rising problem in our country now. In children less than 5 years, overweight and obesity is considered when the weight for age is more than +2 st and weight for length is more than +2 st. Weight for height is also less than more than +2 st. So if the child is growing above this green zone, here we call it as overweight and obesity. In a child of more than 5 years, if it is beyond this green zone, we call it as also obesity or overweight. So this is in a child who is more than 5 years. It is overweight. We consider overweight if the BMI for age between +1 is to +2 st. So this range is above this green zone. Between +1 st to +2 st is called as overweight. And if the BMI is above +2 st, we call it as obesity. This is children more than 5 years and this is children less than 5 years. And as I told you, micronutrient deficiencies is another aspect of this triple burden of malnutrition. There are common deficiencies among our children. Iron and zinc deficiency go hand in hand. When the child is having iron deficiency, we should think there should be zinc deficiency because zinc levels are not done routinely in our setting because we don't have enough resources. But we can do full blood count if needed, serum ferritin level. So from that we can find out the iron deficiency. If it is there, iron deficiency is there, we should treat them accordingly. It is very good practice if you can prescribe zinc supplementation when you give iron treatment. As I told you earlier, these deficiencies go together. So vitamin D deficiency is mainly very common among obese children due to their high fat content in the body. But anyhow, we don't have much facilities to do vitamin D levels freely in our country. So if there is really good indications, we can always go for the vitamin D levels, and sometimes we do have to prescribe vitamin D levels according to guidelines in the absence of vitamin D levels as well. So but anyhow, we have to think about vitamin D deficiency mainly in obese children but also it is common in malnourished children as well. So, my recommendation is it is very good to prescribe a combined mineral and vitamin supplementation for these malnourished children. So when you're prescribing a nutrition plan to a children, it is very important that you know the nutritional requirement of a normally nourished child. We discuss about the nutritional requirement of severely wasted child and moderately wasted child. And normally nourished child, the nutritional requirement is very important because these, even though the child is normally nourished, he may be getting a NG feed or else peg feeds or else jejunal stomach feeds. So we have to calculate the calories. For the first 10 kilograms, we should give 110 kilocalories per kg per day. For the second 10 kilograms, we should give 10 kilocalories per 70 kilocalories per kg per day, and remaining weight 30 kilocalories per kg per day. And maintenance fluids also very important. Together with this nutritional plan, we should calculate the maintenance fluid. Otherwise, child might go into dehydration, mainly if the child is getting enteral feeds such as NG feeds or peg feeds. For the first 10 kilograms, we should give 100 milliliters per kg per day. Second 10 kilograms, 50 milliliters per kg per day. And remaining weight, we should give 20 ml per kg per day. So it is very easy to remember 150-20, or we call it a 4-to-1 regime. According to that, we have to calculate the maintenance fluid. So calculate these calories, we should know what are the calories in common foods. In 1 cup of rice, there is 160 kilocalories. In 1 cup of pulse, 200 kilocalories. In breast milk, there is 70 kilocalories per 100 ml. In formula milk, 67 kilocalories in 100 ml. In 1 egg, there is 70 kilocalories. In 1 piece of fish, which is equal to 30 grams, there is 35 kilocalories. In BP100 one tab, which I was talking about, this ready-to-use therapeutic food, which is 28 grams, that is a 1 tablet, it contains 150 kilocalories. In Triposha, there is 200 kilocalories in 3 tablespoons, which is similar to 50 grams of Triposha. In fat, in 1 teaspoon, there is 40 kilocalories. So from this, you can appreciate fat is highest in calories in relation to the amount. And BP100 also, in 28 grams, we have 150 kilocalories. So it is a very easy way to deliver nutrients, energy to a child who is having wasting. If we talk about complementary food, we start complementary food at the age of 6 months routinely if the growth is satisfied, if there is no growth faltering. But if there is growth faltering or any other concern, we should start it around 4 months of age. And if there is growth faltering, we should introduce fat as early as possible. As I told you earlier, fat is very high in energy. And there is limitation of nutrient absorption in food made from legumes and grains. So what we advise is extrusion products are easily absorbed. That is why we are prescribing Triposha. It has introduced to the children's feeding practices. According to the evidence available, extrusion products are very easily absorbable, and it is very good for the malnourished children. While we are giving complementary feeds, we have to give variety of food. By the age of 7 months, we should give 1 to 2 snacks per day, which are energy days. And later, we should increase the snacks even up to 3 snacks per day. So when you start complementary feeding, we should always advise the mother on structured breastfeeding. Otherwise, this complementary feeding will fail and child might go into growth faltering, even wasting. So it is very important to look into structured breastfeeding. That is, like after taking a baby a main meal, we can ask the mother to give breastfeeds, and after breastfeed we can ask the mother to give water if the fluid is not enough, and later we can allow the baby to play. So likewise, we should have a proper plan, otherwise baby will not eat properly. Between these feeds there should be these main meals and snacks, there should be at least 3 hours gap. Otherwise the gastric emptying will not take place. It will hinder the appetite of the baby. We'll talk a little bit about feeding during and after illness. It is very important to maintain the nutrition of infants and children during a bout of illness due to growth faltering. Children's nutritional needs increase during illness while their appetite may decrease. Therefore, feeding, including breastfeeding, has to be continued and extra meal has to be given during illness. Fluid intake is very important with infections. Dehydration, fluid intake has to be increased during illness. And children should be encouraged to eat if their appetite is poor. And we should offer children their favorite foods. Those should be soft and varied and appetizing. If we offer the same food again and again, if the child is refusing during this illness, actually he might not take anything. So it is very good if you can offer various type of food. And small frequent meals are recommended. Those should be energy dense. So have to offer frequently, like 2 to 3 hourly. For this feed, we can add fat to give more energy. This is a sample nutrition plan of a child with wasting or growth faltering. So as I told you earlier, there should be at least 3-hour gap between main meal and the snack to have the gastric empty. Otherwise, there won't be good appetite. So what we see in the feeding practices, mothers who are very enthusiastic on feeding, they give feeds like every hourly or 2 hourly. It's not a very good practice. So you should advise them on proper feeding practices to have at least 3 hours gap prior to a main meal. So in between these main meals, we should give only water. And water also to be restricted half an hour prior to a main meal. And if the appetite is very low, we have to give appetite stimulants. Sorry. Sometimes we have to go for appetite stimulants. If we prescribe appetite stimulant, it should be given half an hour before meals. These stimulants are actually not vitamins or minerals, they are just drugs. So we should prescribe it for a very short time. And we should ask them we should ask them not to give biscuits and bakery products because they will hinder the appetite. What we can do? Do the nutrition assessment at the primary care level and at the admission to the ward, and educate the healthcare workers, professionals on identification and management of malnutrition. And you should refer early to the closest medical nutrition unit or hospital if any nutrition problem identified that needs further intervention. So from this, what I'm trying to tell is it's very important that you do the nutritional assessment at the primary care level and educate your junior staff on identification and management and referral to the earliest as early as possible. Take home message is it is very important to identify malnutrition in children. Timely referral and management need knowledge, and your contribution can help in making a better world. So that's the end of my presentation. I would like to take any questions if you have.
Thank you, Dr. Malnutrition, for that interesting and very informative lecture. And we have received one question from our audience. How many eggs can you give for a normally growing child?
Of course, we can give 1 egg per day. Sometimes, actually, if the child's demand is high, it's not bad practice to give at least 2 eggs per day when the child is growing. So, usual recommendation is 1 egg per day, but sometimes in children who's having like burns, involved patients with high protein requirement, we can go for high energy. Like when we have to deliver a lot of proteins, we go for more than 1 egg. For your question, for a normally growing child, usual recommendation is 1 egg per day.
Thank you very much for that answer. And another question from me, can you prescribe BP100 for all the children with severe malnutrition, as you discussed in the lecture?
Yeah, actually, BP100 is a therapeutic food with a lot of energy, but there are a lot of solutes like potassium is high, sodium is very high. So, in renal diseases, there might be high potassium levels in the body. Hyperkalemia is there. Some are on management drugs for hyperkalemia. So, at that stage, we should not be prescribing BP100. So, should be very careful when prescribing BP100.
Thank you very much for attending that question as well. And we have another questions coming up. Any age limit for BP100 to give?
Yeah, as I told you earlier, it should be given to children less than 5 years of age. It is starting at the age of 6 months. So if the child is more than 5 years, we should not recommend it routinely. But if there is real indication like child is injured, fed, or having critical illness, if there is nothing to give in the hospital setting, so if in the absence of formula in the hospital, sometimes we go for BP100. But the routine recommendation is to give BP100 during 6 months to 5 years of age.
Thank you. And the next question is, can we use BP100 in sick days of normal child if the child is sick?
Yeah. As I discussed in this rehabilitation phase, we shift the child from F100 to RUTF, that is to BP100, when the child is not having any acute medical problems. So we can give BP100 when the child is recovering from sickness, but of course, like if the child is having a bit of a fever and respiratory tract infection, it's not a contraindication to give BP100. Yeah, of course, we can give BP100 when the child is also sick. As an outpatient as well, if the baby is having any sickness, we can always advise mother to continue BP100 if the child is not refusing it.
And the next question is, any recommendation to start yogurt and cheese, and can we give that to 6 months old baby?
Yeah, actually, we can ask these mothers to give yogurts at the age of 6 months. The problem is, our yogurt in our country, yogurts are very high in sugar. So, like when we introduce sugar, the child's taste might change. So he might refuse normal food, right? The complementary food he might refuse. So it's not very good to give yogurts routinely, but in the absence of proper food, like parents, caregivers always can't make a lot of food for them. They are going to the jobs and children are kept with the grandparents, so it's very difficult to give snacks to these children always, like they can't make homemade food always. So in that situation we can give yogurt as a snack. Actually it should be a sugar free yogurt. In the absence of that, we can go for this normal yogurt in the market. And cheese, of course, it is not very high in calories. It contains a little bit of energy, and there is not much of a nutrition value in relation to the money that you spend on. So of course we can give cheese, but the problem is the worthness of that. It is not worth to the amount of money you spend, and it is very high in salt. So as I told earlier, like for the sugar, it also can change the baby's appetite. We are not giving much of salt before the age of 1 year. So as this is very high in salt, it is not very good practice to introduce salt. So we are talking about reducing salt to prevent hypertension and all those things. So I don't think cheese is a good snack because like all these problems, high salt and low energy in compared to the cost.
Okay, thank you. And I hope all have received their answers for their questions. So let's end up this session. And let me thank Dr. Malnutrition, who is the consultant clinical nutrition physician at Lady Ridgeway Hospital, for attending today. And let me thank the audience as well for your questions and being there with us. And see you in 2 weeks' time. Have a good day.